Too many days in the darkness.
Welcome to Prevention is Cure, brought to you by precure.com, the podcast which brings you the latest in science and practice and challenging mainstream medicine and finding new and exciting ways of having a happier and healthy life. This series is looking specifically at mental health. We've become really concerned about the lack of translation of what science knows into what medicine does. In most societies, including the one I live in, 1 in 5 of us will have a serious mental health problem at some stage. The infrastructure, the practice, the gap between treatment and best practice is massive. This podcast series aims to do something about it. Prevention is Cure. I'm your host, Professor Grant Schofield. In this episode, I interview Professor Julia Rucklidge. I hope most of you have heard of Julia Rucklidge. She is a nutritional psychologist. I guess she's a practicing clinical psychologist and a professor of psychology at the University of Canterbury in New Zealand, and she's most famous, I guess, for her very careful use of randomized controlled trials to discover the effect of micronutrients on mental health. And she has some powerful and fantastic research. She's a very, very careful woman, very careful and fastidious with her research. You're going to love this podcast. We also discuss her new book, The Better Brain, a great read about this exact topic, putting forward her and other people's research showing how powerful a tool diet and especially micronutrient supplementation is for that major unaddressed elephant in the room in society, our mental health issues. Without further ado, enjoy the podcast. Here's Julia Rucklidge.
Too many days in the darkness without a glimpse of the light. Running tired and broken and scared, but I swear I'll never give up the fight.
Welcome, Julia Rucklidge. Good to have you on the podcast again, and congratulations on your new book, The Better Brain. It's a great read.
Great. Well, thanks, Grant. It's always a pleasure to talk with you and chat with you about this area of research. I'm thrilled to be here.
Okay, so before we get, well, it's actually chapter 1 in the book, and I did read in a otherwise very, very positive review in Psychology Today this morning, where they slated you on chapter 1 and said, well, chapter 1 is so obvious. I don't even know what she's covering it, and it's boring. It's about this treatment gap. Actually struck me it's exactly the opposite. It's not boring, it's interesting, and everyone needs to know about it. So tell us about the treatment gap.
Sure. I mean, I think what we did in chapter 1 was talked about where we are right now. And that's, you have to position a book about where are we currently standing in terms of the mental health crisis and how people are going in terms of their mental health nationally and internationally. So you got to set the scene. So you've got to have a chapter 1 before you can delve in and start to talk about some new solutions. So, I think about the treatment gap as those number of people who are currently not receiving any treatment, but who struggle with a mental health issue. And we know in New Zealand, that's a really big problem. And it's, only 3% of the population have access to mental health services. You have to be in the severe range in order to be able to get into the clinics, into the public health system. If you're mild, even moderate, you're getting turned away. I read stories about kids who are not suicidal enough in order to get into the services. So we know this is a huge problem, and it's got to do with having a lack of professionals to adequately address the mental health issues that are present in New Zealand. There's just not enough of them.
That's true worldwide.
Yeah, absolutely. Yeah, that's good. Because if you think about the numbers, I mean, this number that gets thrown around, it's about 20%. 1 in 5 of us is struggling with a mental health issue. I mean, that kind of depends on how you want to define it. I mean, I think everybody struggles to some extent at some point in their life with a mental health issue. Do you need to see professional services? Not necessarily, but to sort of acknowledge that struggling with depression, struggling with anxiety can be a normal part of life. We don't have to pathologize it. And so that's, I'm not always excited about, or not excited, but thrilled about the way we throw that number around, because it's probably a lot more than that, who are struggling in some way. And I just, it's funny how with physical health we're okay with everybody is going to needs to look after their physical health, and we all need to look after our heart health, and we need to make sure that we're eating adequately to ensure that we don't go down a path of, say, type 2 diabetes, et cetera. But we just don't think about that in terms of mental health. We seem to think that that's reserved for a certain part of the population, when that's just not right. It's, we're all there. So yeah, sorry, do you want to jump in?
I was just wondering how it got to be such this gap between professional health and infrastructure to help, and also when it's such a newsworthy item, and there seems to be quite a lot of investment in what's mental health.
Well, I wonder if it's because it's been the treatments and the diagnosis. I'm just throwing out thoughts, is that it's dominated by psychiatrists and psychologists, maybe, and they've got their treatment ideas around how to help them. And for some people, those treatments can be really effective. So, for some medications work. I would argue not well enough. There's too many people that I've heard of who really don't get it into a place of wellness with medications. In fact, I sometimes even wonder if people think I'm depressed and I'm on an antidepressant, therefore I should be depressed. Like, it's kind of, which is an odd way of thinking about it, but I've certainly seen that quite a bit over my career. And psychologists have really pushed hard to introduce the psychotherapy into the mainstream care, and good on them. I mean, they've fought for that over decades. But it was at a time, maybe if we think about it, if it was at a time, if we, when psychotherapy would have been thrown into the mix, would be 60s, 70s, maybe, at a time when maybe there were fewer people with mental health problems, possibly, but they also sort of cornered the market and really have built up barriers to people being able to come in and, like wellness coaches or, allied health professionals, from being able to offer those, those therapeutic interventions. And they've kind of created their own little niche, which I don't think has been a great thing for the service of the public. I don't know if you agree with that or not, Grant.
I 100% agree with that. I mean, there's so many hooks in what you've just said. I mean, I just want to touch on a few of them one at a time.
Sure.
The first is around, I guess, psychiatry and medicines and medications. And the thing that struck me when I've been looking at a lot more into mental health in the last year, a lot more. And if I look at our best practice guidelines, you can look at the bpac.gov.nz in this country, and it's got quite specific, clear guidelines about the treatment for mild or moderate depression. And even for major depressive disorder. And it's very clear that medicines for mild or moderate should never be the first-line treatment.
They are, though.
And it quite clearly and specifically lists out a range of evidence-based therapies which start with exercise and physical activity. It mentions nutrition and diet. It mentions sleep. It mentions talk therapies and connecting with other people.
But we don't have enough professionals. That's
right. But we don't even have. But even if we don't have the infrastructure, even within the professionals that we have, right?
Well, we don't have the infrastructure. There's no way. I mean, I train in a clinical psychology program, and we have, over the time I've been here, we have doubled the number of students. We've gone from 8 to 16 now, and we are seriously struggling with training 16 clinical psychologists per year, because we don't have the internships, we don't have the placements for them, we don't have enough staff to be able to one-on-one monitor them and supervise them, which is essential for them to get that expertise in conducting cognitive behavior therapy. So we have a model that requires an enormous amount of investment to train them and an enormous amount of time for them to get through. And so you have a bottleneck in the terms of the number of psychologists you can ever graduate in 1 year. So when they say we just need more of them and that's the solution, goodness, you need to do a fairly major more of them, like double, triple the workforce, and still you're not going to adequately get that to hit that 20%. So we've got a model that, yes, it's ideal perhaps, although one might argue that still only 50% of people get better with psychotherapy. So you've got this model where we're expecting a really intense level of training, and you will never be able to get the number of people needed to adequately hit, to be able to service that 20% of the population. And it's not achievable, and nor is it's something that our country can afford. So that's why I think the Better Brain kind of it presents a really different way of thinking about mental health, to say, one of the factors and risk factors that is being really emerging over the last decade is our nutritional foundation. It's just been eroded because of this social experiment of eating ultra processed foods. So if we could just address tackle that, which maybe that's harder than training more psychologists. I don't know.
The solution I've been thinking about is in this health coaching and sort of mental health coaching and community health workers, which is a workforce, and we in Western New Zealand, and I know it's happening in other countries as well, we see these health improvement practitioners who have some training, and there seems to be some evidence that they're achieving something without the level of training of a clinical psychologist, but certainly interacting and being overseen by.
Yeah, and we need that. We need that. Oh, I'm all for saving the most severe. The most severe ones for clinical psychologists, but with mild levels of depression, then absolutely you can open that up to other professionals who've got some training in the principles of cognitive behavior therapy or other therapeutic modalities. It doesn't require the really, really intense training that clinical psychologists go through, because that's really hitting that severe end.
Yeah, right. Okay.
And we definitely need to be less protective. Turf protection probably plays a role in here. So I think if we could just collectively stand back and just go, does turf protection help or hinder the achieving better mental health for our population? We might sort of say that it's probably it might sometimes get in the way.
Okay, because I'll give you a couple of examples from my suburb. If you go to your general practitioner here and you've got a mild or moderate problem, well, there's really nothing to be referred to other than private.
Yes.
And there's a couple of services just up the street from me. One more focused on young people, but young adults as well. And you can expect under that private thing to have a 4-month wait at the moment to see a psychologist and a 12-month wait to see a psychiatrist, and you can expect to pay $350 an hour for an appointment. Mm-hmm. So that's completely booked out. There's no private. And having known of a mother who rang the crisis line recently, they were asked if she was in danger of committing suicide at that moment. Mm-hmm. She wasn't. I mean, she was suicidal, but not at that exact moment. And they asked her if she'd asked her daughter how she was feeling, which I think had actually occurred to her. And then they said, well, you could go and see your general practitioner. So the service treatment gap of anything coherent is from a just a parent and a member of society's point of view is quite despairing, so far as I'm concerned. And I think I listened to a great talk you did at University of Canterbury. It was put online recently, and you talked about what the number that really struck me is you talked about the population of the South Island, which I think was 910,000 or something like that from memory. Am I right?
Yeah, that's right.
As being the number of people in New Zealand who require treatment, and half of those
exactly.
Was that what's all right with those numbers?
Well, so the South Island is a fifth of the population, and that was what I was trying to put there. And then I gave a picture then of Christchurch, because that's the population of Christchurch is about 400,000, and so that gives you an idea of the number of people who are not currently getting treatment in New Zealand in any one given year. So it's about 40% of the population, and then I give numbers of the number of psychologists and allied health professionals that we have, and just that, and that's where I I came up with that 40%, was based on how many there are registered in the country. I think it's about 3,500 psychologists, and probably, although it's kind of hard to know the number of allied health professionals because they're not all registered, I estimated it might be about the same number, but that may be wrong. But I'm guessing it's about the same. And so there was no way, like, to then double that workforce to get from, say, 7,000 to 14,000. And we've just increased our number of students that we train in our program, by a few. You're not going to cut it. You just can't get anywhere near with the numbers that you need to really just hit that full array of being able to really adequately address that, that phone call from that mother. You just can't, we don't have enough of them. And they're all, I see them all online, the psychologists, all their private practices, they all say waiting list is closed. Our clinic in Canterbury at the University of Canterbury is closed for wait list. So that's a really concerning place for us, where the model that we've developed as a society to help people is just not, it's not good. It's not adequate. It's just not, it's unfortunately, requiring this really intense level of training, intense level of one-to-one work. So we've got to change the model, unfortunately. It might have worked back with Freud in those days of neurosis, but it's just not, it's not working now.
It's not going to get there. Okay. So before we get down to the really deep and dirty on the nutrition, which I know everyone will be looking forward to, certainly I just want to talk about psychotropic drugs. Yeah. And I'll test your, what you're willing to say here.
Yeah.
Because there's quite a lot of controversy, isn't there, especially in mild to moderate depression and anxiety about the harms versus benefits of particularly SSRIs. What do you say when I say there's controversy about harms versus benefits?
Well, I think some people still think that that's the best line of treatment. And I suppose that's where the controversy comes from, because others are now challenging whether or not that really is the case. And it's a big debate amongst researchers as well. Is like, well, and I think about this a lot. I think, well, there's this issue of, if you look at mild to moderate, one of the reasons why they say that is because there's no group difference between those who are randomized to an SSRI versus those who are randomized to a placebo. So very, very small and not a clinically significant group difference. Sometimes it might be statistically different, but it's not really that clinically meaningful.
So people talk about perhaps a 2-point difference on a 50 point scale.
Exactly, very small. But on the flip side, it does work for some people in the sense that when you go on an antidepressant, some people do get better. And I certainly don't want to minimize that. And I think when people say the antidepressants don't work, they're overlooking the fact that actually people do seem to show benefit, but no better than placebo. So how, and then you might say, well, that's the only way we can harness the placebo effect is by giving people an antidepressant, because you can't, how do you trigger the placebo effect without giving somebody a pill? So so some people might say, well, that's okay, then let's just give them an antidepressant because that's how we can trigger the placebo effect. Yeah. But then the flip side of that, and maybe where the controversy also falls in here, is that the side effects are becoming more and more pronounced over time, in that we're becoming more and more aware of them. They're not new, but we're just more aware that people really, 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 really struggle to get off of, some people really struggle to get off of these drugs. So I think the numbers are something like 50% of people experience withdrawal coming off of a drug, and about half of those experience that as severe, to the point where people won't come off drugs because it's unpleasant.
And there's a problem. So let's take one SSRI. So venlafaxine's an interesting one. So you look at some of the side effects, and there's a known side effects, insomnia and nightmares, these sorts of things, suicidal thoughts. Generally not things you want to accompany your treatment.
No, and sexual dysfunction is one that often people don't talk about, but it's a really big problem.
Well. But part of the problem is when you're coming off them, the withdrawal exacerbates those side effect symptoms. So then people will get the feeling that, in fact, the SSRI was masking those symptoms in the first place, when in fact that's not the case, right?
Yeah, well, that's definitely the old way of thinking about it. Like a sort of, and I can understand where people would come from if they're thinking that what these drugs are doing is correcting this chemical imbalance, which is something that's being propagated by the drug companies as an explanation as to why SSRIs work. That might also add into the controversy that you talk about, because whenever anybody says to me they have a chemical imbalance and that's why they have to take an SSRI, I say, did the doctor do a level of your serotonin? I'm just really curious. Did somebody know? Well, and then they're kind of a little bit kind of maybe taken aback, but that's the story it's a story that really comforts them, I think, and provides that evidence, like sort of that my brain is broken and therefore I need this drug.
So you don't buy into this mono A and serotonin imbalance hypothesis? I probably don't.
I don't think like it would be kind of, I think a better way of thinking about it is kind of thinking about it like alcohol. So, alcohol has an effect on our brain. It has an effect on our neurotransmitters. It plays around with that's what's happening. We become less socially inhibited. So yes, it has an effect on our behavior, but that doesn't mean that I had an alcohol deficiency. So,
right. Okay, I got it.
So maybe that's maybe a better way to think about what these chemicals are doing, because they are having an effect on our serotonergic system. We know that's been really well shown with animal models. So there's definitely a change that happens at the synaptic level and changing the amount of serotonin that's available within the synaptic cleft. So there's definitely a change that happens, but whether or not the individual was deficient to begin with is still something that no one has ever been able to adequately prove.
Okay, it's part of the problem, just understanding how the brain works in the first place, the complexity of this organ.
I don't pretend to know everything.
Yeah, right. So, and you didn't just come through as a psychologist, you also came through as a neuroscientist, right? So
that's right. Yeah. I do. I have a background in neurobiology. Yeah. So so the controversy of the drugs, there was something else I was going to say about it.
So one more thing on that then, just to push you a little bit further, is around the differential effect for the developing brain, especially through adolescence, especially in the frontal lobes and the hippocampus, and this idea of reduced plasticity when you're on SSRIs and stuff, that sort of thing.
Yeah, I mean, there's certainly research that can be worrying if you choose to look at it. If you were taking these medications or considering using them for children, and I think this is what I was going to say is that you've got to weigh up the pros and cons. You've got somebody who's really, really distressed, and so the pros of using these medications may be that you might alleviate some of that suffering, but the cons are that there are definitely some established neuronal changes that can happen when you are put on these medications, and then long term it could also have damaging effects as well, an uncertain risk.
And that was really the controversy in your now very famous TED talk.
Definitely.
The long-term effects, right? So
exactly.
We're not seeing a curative effect, and when there may be evidence of harm.
Yeah, and so going back to that decision of using the SSRIs for mild to moderate, some people might argue, well, we have to give it in order to harness the placebo effect, but others will argue, like Irving Kirsch will say, but you're causing harm, so there must be a better way of harnessing the placebo effect than giving them something that they're going to be then addicted to for many, many years, if not forever. I mean, I know people in their 80s who can't come off of some of the benzos that they were put on back in the time of Mother's Little Helper. So yeah.
So people we'll put some links through to this, but Irving Kirsch's work is he wasn't really a depression researcher as such as a placebo researcher, and he really waded into the.
He sure did. And
I guess he's still in that mire.
Yeah.
Yes. Okay. The last medicines question is really around this change of diagnosis. So if you go to a psychologist or psychiatrist or a doctor and you get a diagnosis when you're a child versus an adolescent, then you see this really high level of diagnosis of ADHD for the younger ones, and that switches to a depression and anxiety diagnosis in the
it can.
Teenagers. What's going on there?
Are
they the same thing? Are we missing something, or are we misdiagnosing, or are we just overdiagnosing?
You're just asking a really tricky question. I don't know if I can give a great answer. I mean, I have to say, after doing this research on nutrient interventions, and also even if you want to think about the dietary change research, where people manipulate diet and they see whether or not people get better, and also the countless number of stories I've heard over the years. If I put that together collectively, you can't help go that there's no box in our brain for ADHD, and there's no special place for depression, or no special place for anxiety. We've got these diagnoses that are seen as helpful in communication amongst professionals, and communication with clients, perhaps in sort of explaining away their problems. This is what you've got is ADHD. We've got, there's research that's got these links and risks that lead you to be more likely to express these symptoms. But I don't think I don't no longer see them as being these separate identities.
Okay, that's a really good point. Yeah.
Yeah. I'm more interested in them as I think with the clients, the people who are struggling with these symptoms, what they're probably more interested in, and I might be a little bit wrong on this, is that they're interested in the symptoms that are impairing them. They're interested in, that's what they want to see get better. They're not interested in, per se, that this diagnosis goes away. They want alleviation from suffering. So do the diagnoses help us in that, or do they kind of create this smoke screen of, you have this disorder condition and therefore you need this type of treatment, which really fits well with a medical model. But I don't think we have enough really and this is certainly being challenged a lot by many, many writers over the last decade or so, which is around, do we have an adequate amount of data to really support these individual sort of cluster of categories? I don't know.
Okay, yeah, I have no idea what the answer was. So
okay, well, I don't know either. So, but that's kind of some of my thoughts. I'm not as wedded as I was. I'm no longer as wedded to the diagnostic categories as I was when I first started training as a clinical psychologist. We do talk about the diagnostic categories in the book because they're there. People understand them. We felt we couldn't challenge everything in one book, so we had to let go of kind of delving too much into the whole, did these diagnoses, where's the evidence for them? How solid is it? We chose to not go down that route because it would have taken a lot of more pages.
Okay, well, let's talk more about the better brain and the nutrition side of things. I think it's time we actually get into the
Sure.
really interesting stuff. I guess the first thing I'm curious about to update people from last time, because there's been quite a lot of discussion about this, and you and your colleagues Neville Blampede and co have been writing journal articles and letters and things, particularly about your Christchurch earthquake and your post-traumatic stress data. Can we just talk about that for a moment, about the role of nutrients and the accidental finding? Is it accidental? I guess you were doing a trial, then an earthquake came along, right?
Exactly, pretty much. Yeah, it was an accidental finding for sure. That really, so there was the September 2010 earthquake where we happened to have people who were taking nutrients, and we happened to have people who weren't taking nutrients, just based on where they were in a clinical trial. So we could ask this question of people who are better nourished before a stressor comes along, do they recover more quickly from the stress of an earthquake? And the answer is yes, they do. Yes, they get stressed. Boom. Yeah, their stress levels go up after 1 week, but then they start to decline, and they decline much more quickly in the people who weren't taking the nutrients.
And how are you measuring that? Because I saw some results that were big magnitudes, and I was like, whoa.
We were using the depression, anxiety, and stress scale, which is pretty standard scale to use in experimental research. So that's asking questions. It's not doing it. I don't know if you're trying to ask whether or not we had biomarkers. We didn't. No.
I was just interested in the sort of size of the differences, and I think
I know. It was large. It was a magnitude of over 1 point in terms of effect size. Definitely,
right.
Very large, very large differences.
So
my memory of it.
And just tell us about what you've been writing about that with your frustrations around translating policy and the government taking it seriously and that sort of thing.
I know. So, I mean, that to me really opened up this idea that nutrition provides us with resilience, and it makes us more resilient when we are faced with stressors. I don't think there's any more stressors now than there were when, for our ancestors. I mean, they had their own issues. They didn't have antibiotics. They had constant infections. They've had pandemics. They've had wars. We can think that we live in a stressful time, but I don't think we could really strongly argue that it's any worse than it has before. But I think what may have changed is that because we've been eating ultra-processed food, and if you look at the data, it's very clear that half of our calories are coming from ultra-processed foods. And I think it was you, or maybe you gave me the statistic. I can't remember who. It was somebody in New Zealand where 2/3 of the foods that are sold in a supermarket are ultra-processed. And so
that was the University of Auckland Cleona's study, which I think they had in shopping trolleys at supermarkets, that 69% of what people take home would be called ultra processed. So it's pretty appalling, but it makes it checks out sort of as a sort of face validity, right? You sidle up next to someone in the supermarket and you glance into their trolley. I mean, that's what you see.
That's right. I did this MOOC, the Mass Open Online Access course, where I had to do these videos about what's ultra processed food and what's processed food and what's real food, just to educate. Yep. And I had to go into a supermarket and just buy ultra processed food. It was one of those what's the word? Just so embarrassed about my trolley.
So you're walking up and down the aisles, grabbing Doritos.
And then I ran into an integrative physician in the community, and she's looking at going, this isn't what it looks like. And she's like, I'm not judging you. And I'm like, yes, you are.
It's a work project.
It's a work project. I had to spend $200 on ultra processed food. It was, I mean, was it fun? It was an interesting thing, but it wasn't hard. It certainly wasn't hard to fill the trolley with a bunch of crap. So just to sort of explain an idea.
I guess your hypothesis and your data, because you're really data-driven, a data-driven scientist, in the better brain, is that nutrients, especially when they can be applied in a placebo randomized trial, which you can do with the sort of high dose nutrients that you're doing, and you're doing them at not recommended allowances, but more maximum tolerable allowances.
Higher,
put them out. Actually have some benefit, and for some people may be curative on
absolutely
across a range of things. And you've tended to concentrate on young people.
Oh no, we've gone across the ages. We've got some adult trials, we've got child trials as well. Yep. But even when you say that, I'm even now challenging the recommended dietary allowance numbers and metrics, and that's partly because I've looked at, I've done these graphs which I find to really illustrate the concept really nicely, where you put on the y-axis all your minerals and vitamins, as many as I can fit on there, and then on your x-axis you put I'm looking at the percentage that a food has relative to recommended dietary allowance. And so I go through a bunch of ultra processed foods like, French fries and Spam and donuts and, those hot dogs, that kind of white bread, crackers. And the number just doesn't even go above 20%.
Right. Yeah,
so
they're devoid of nutrients.
They are really devoid of the nutrients. And so I suppose you could work really hard at eating those foods to hit 100%. You could do it, but you probably wouldn't actually go that much higher. So you almost wonder whether or not this is a collusion between, the ultra pro. I'm probably making this up, but is it possible there's some kind of collusion between the food industry and these dietary recommendations that allow the foods to kind of fit within that?
Yeah, they sort of exist in a space that's
right.
healthy, which is complete nonsense. And actually, in fact, there's no real nutrients in the middle.
That's right. But then if you look at real foods and you do the same thing, you're actually going way over RDA if you're eating good foods. You're going to go way over. And nobody's screaming and going, oh my God, don't eat too many vegetables because you're going to get too many nutrients out of your food. I've never heard that story. But then when it comes to taking nutrients in a pill form above that 100%, everyone screams, they think you're killing people. It's quite an interesting contrast. So I just wanted to challenge that whole concept that we're giving them at really high doses.
That's a really good point.
Yeah, but it's not until I graphed it that I came to that conclusion that actually you can really easily go over 100% if you're eating real whole foods, hopefully.
And so the sort of nutrients that you're talking about in your supplements. Let's
Not
just
mine,
run through those. But we're
ones that
talking
I
about
study.
zinc, magnesium,
Yeah.
copper,
Nothing.
iron, calcium, B12,
Selenium.
folate.
Yeah.
What are some I'm missing out on?
Your vitamin A, D, C, the full array of about 15 minerals that our plants get out of the soil, and about 15 vitamins that the plants will make from when the minerals are uptaken from the soil.
How do those compare with even a sort of physician or practitioner grade multi that you can buy from off the shelf sort of thing? These are way stronger.
Won't compare. In fact, I'm at the point where I think the one a days are your ultra processed equivalent to what you really should be taking, right?
Yeah, right.
So they're just at that really, really low level. You'll survive with this, but you're not going to thrive with this. So
okay. So what advice? Here's a question that got thrown to me. I was giving a talk at a law firm a couple of weeks ago. We're talking about well-being, but amongst other things, nutrients came up. Questions at the end. Young lawyer at the back goes, my parents just take all these supplements, and I roll my eyes and think these people are out to lunch. My idiot parents. What do you think? They should just eat whole food, right? And I was like, well, I used to say that.
Yeah.
Let me tell you about Julia Rucklidge's work.
Right.
And I say, well, and it's there's questions about what's actually even in our food. Even the stuff that we would consider as whole food, unprocessed food, fruits and vegetables, and
exactly. Yeah, exactly. I mean, there's
animals and stuff.
Yeah,
what do you got to say about that?
Well, I mean, that's something that we spend a whole chapter on in the book, is looking at soil health and the mineral content of our soils, and then we're not replenishing them adequately with all the full array of minerals. We think about just throwing a few in. It's just like ultra processed food in a way. We're just throwing a few in and thinking that that's going to be adequate. And so we're coming really, and it's amazing how many farmers and soil scientists have been contacting me saying, you're so right, where our soils are really are a massive problem in New Zealand, that they aren't, we're not hitting how much they should be for an ideal soil climate.
Does the speed of growing and the time of storage make any difference?
It certainly makes sense that it'll affect it. Is that the faster it grows, the less opportunity it has to take the minerals up from the soil. And so then we select for those foods. I mean, I get the challenge. We've got a lot of mouths to feed. And so selecting crops that are going to grow quickly, store well, transport well, look beautiful is going to be the top priority, and not its nutritional density. So we've got some pretty major challenges to overcome to get to a place where our soil is adequately providing the nutrients that plant needs. But then we throw things on it, and we throw glyphosate on it, and then we put glyphosate on as the desiccant right at the end of the crop growth, and that's just that has an effect of just goes into the soil. It's a chelator, holds onto the minerals, and then can wash it away in the next rainfall.
I was unaware of that. That's interesting, isn't it?
I know. Yeah, no, that's something that I've just learned from a toxicologist, is that the effect it can have once it enters the soil. So there's some worrying things there that we've got to be aware of and understand that it's having an effect on human health. And it won't just be mental, it'll be physical too.
So just to save people emailing you, which I imagine thousands of people do.
Yes.
And so I know the answer when people ask me. Mm-hmm. The question I'm going to ask you. It's like,
I don't know.
I've read your trials. I want to get some of these high dose things, either for myself or, an example, last Friday, son of someone we'd met who had a 16-year-old boy who had attempted suicide the previous week, and they've read your stuff and they want to get these high dose nutrients. How or where can they do that? How do you even go about doing such a thing?
Yeah, I mean, the nutrients that we've studied, it's not a secret, but I tend not to just go around advertising it because I don't sell them. And I can always look like I'm in cahoots with the industry and I'm just here to make a whole bunch of money off supplements. I'm not. No money comes to me at all. But the ones that we've studied the most is daily essential nutrients, which is available in New Zealand. Yep. The challenge, though, here, Grant, is that the laws in New Zealand and, of course, overseas are such that they make it really difficult to take supplements in a therapeutic dose. So the regulation, and I do think this conversation has to happen if we're going to move into thinking we're going to use more supplements for the treatment of mental health issues, is that supplements are regulated as foods in New Zealand, not as medicines.
Mm-hmm.
And there's a few that are regulated as medicines, like, say, for example, lithium or folic acid. It can be prescribed to women during pregnancy, or vitamin D at a higher level, that kind of thing. But for the most part, supplements are regulated as foods. And that means that you cannot have a therapeutic benefit to it. So it's a minefield for consumers to kind of go, well, what do I buy? Do I go into a supermarket to buy one of these one-a-days? Well, I'm going to basically say that I don't think the doses are going to be adequate for those one-a-days. But then to get access to the nutrients that do have therapeutic benefit, you've got to you've got to work around the legislation to make sure that it's done legally. And so the way this is managed is that you've got, in order to buy the nutrients and use them at the doses that are therapeutic that we've shown in the clinical trials, you need your doctor to be involved. So it's like using it almost like an unapproved medicine. That would be
but people can, and people want that insurance, so people could go ahead and do that. Like they can talk to
they could do that. Yes, exactly.
Say, and I've been looking at these trials and I'm really interested in this,
yeah,
and my son this, or my daughter this, or whatever.
Yeah, but they have to get the physician to agree to it. And as we know, not all physicians are well educated on supplements. And so they'll often say, well, that's a waste of your money. Don't go down that route. There's no evidence that kind of, line.
Intelligent people can print out the randomized trials, can't they?
You'd hope so, but they don't always bother because they've been sold the idea that supplements don't work, right? I mean, I'm constantly, hear physicians will tell me that it's just expensive urine, and I'm like, oh, you know what? I'm respectful of your education, but it's wrong. You need to, here's all the updated evidence. And it's not like I publish it in crap journals either. I've gotten this research published in a really good journal. So it's not like it's not out there. It doesn't exist. It's just people choose not to read it. It doesn't fit with their medical worldview. It'd be hard. It's hard to change. It's hard to change the way we think about medical illnesses or these psychiatric illnesses. And so it takes time for people to kind of get their head around it. I think it's happening. Like, I know that there's more and more people who are physicians who are getting interested, but it's slow. But the public don't have time to wait for them to catch up. And that's why I just wanted to explain the challenges of getting access to the nutrients. It's not always simple. And that's because of the legislation. So
but it is
absolutely, there's a workaround around it to get access to them. You could buy them and not use them at the therapeutic dose, because that's the only way it's allowed to be sold in New Zealand. Is it a dose that doesn't work, or at least that we haven't used in our clinical trials? But people hopefully will understand that that's what it has to say on the bottle, but then you need to know what was used in the clinical trial. So it shouldn't be this way. You shouldn't have to do this kind of workaround because pharmaceutical medicines are the only ones that are allowed to have a therapeutic claim associated with them. I'm allowed to say as a researcher, yes, it treats symptoms associated with ADHD.
Yeah.
The people
so what do you make of those? And I'm not selling these or anything, so I'm just interested. I sort of used it a bit with my kids. So you can buy these other sort of, I guess they're multi-nutrient things like this Good Green Vitality or these Athletic Greens, these sort of green powder.
Or Nutrient Rescue, all of,
What do you make of those?
They sound like really good, and they're probably at a dose that's really adequate, I would imagine. And I know that there's lots of anecdotal reports about the benefits. I've heard of Nutrient Rescue, for example, is one of those powders that you mix with some water, but they haven't been tested for the treatment of the mental health issues that we're talking about. So I can't say yes or no. I suppose, what's the harm in trying it and seeing whether or not you feel better? Because that's the bottom line. It's not whether or not your diagnosis goes away. It's whether or not you're operating to the optimal that you want to operate at.
I guess part of the struggle, not for us adults, but us as parents, and I know you're a parent, and I'm dealing with either teenagers or slightly younger or older teenagers on that category. It's not always easy to convince them to eat everything that you'd like them to eat, and they have a tendency to go way off the reservation on occasions, and so you're sort of trying to get things. I'm asked by parents all the time the same thing. What's your response to that?
about whether or not in
just
those
about
cases.
feeding your teenagers.
Yeah, I know. I've got a grazer. Well, he eats a lot. Yeah. A lot. Yeah, those teenage boys. I agree that can be it is a huge challenge, and I don't know if where we could go with this is saying that that our nutritional environment out there in our society, in our community, is one that's really toxic, and that we really need to do something about changing our really toxic food environment that's available to teenagers, because that's what they crave. They often crave those ultra processed foods. It's what they've grown up on, and oftentimes I hear that challenge of how do you get them to eat the real food, and I think that shouldn't be shouldered by the one parent. That needs to be shouldered by our entire community that says enough is enough. There isn't a single study that's shown that these foods are good for us, and yet we seem to think that they're nourishing for life. And when are we going to say, when is our government going to come out with the type of legislation that really, really needs to happen? Kind of like tobacco. That's where I think the conversation needs to go. But I know that's not answering your question particularly adequately.
It's also gets a bigger issue, right? So we did a full review of mental health, at least in New Zealand, and this has happened in virtually every Western country because of the same crisis. And you look at the documentation and the recommendations that have come out in this country and other countries. Why is nutrition not even a topic? I think it's mentioned 4 or 5 times in the report, and it's not in any specificity.
And it certainly wasn't mentioned in the mental health report that was given to the government in 2018. Yeah. Why is that the case? Is it a number of different issues? Is it the number one is that nutrition has been for a long time viewed as being irrelevant to brain health? So it's not even on the radar. So when you do, so we just don't even bother putting it on the radar. But I also think that we've got really some pretty strong and powerful industries that are going to prevent that kind of message from coming out. I mean, I even think about, the ultra processed foods and say even just the nutritional facts that are on there, right? On the back of an ultra processed food package, although it might be on some real foods too. You'll get it on yogurt, you're on your yogurts or your milk. It might also give you the nutritional facts. But for the most part, the focus is on the macronutrients. It's on the fats, the carbs, and the proteins, and not on its micronutrient content. Very, very little information is given about its micronutrients. You might get 1 or 2, but you're not going to get that full array. And that's, I assume that's because if they were forced to put the 30, how well are they doing in terms of your essential micronutrients, they would have a whole bunch of zeros. And so there's been this very clever,
the ones that are essential.
They've got this very, I assume it's only clever to think about, force the public to think about foods from its macronutrient content and not even bother thinking about those micronutrients that we know are so essential for brain activity. So there's a lot that's working against the parent. You've got the star ratings that are supposed to help us in making good choices, but that's
an endorsement of ultra processed food, isn't it? I just want to stand
totally, yes, it is. And as I like to say, is that a cardboard box would get a 4-star rating because it's low in energy, it's low in saturated fats, it's low in sodium, and it's low in sugar. That doesn't mean you have to eat it.
That's well said. I think we're going to quote that one.
What kind of star rating system means that a cardboard box or this glass, this book, my book would get a 4-star rating.
Well, I was giving it a 5-star rating, but that's on a different rating.
Yes, fair enough. But that's a crazy system where it's based on what's not in the food rather than what's in the food. There's only 1 star that's given to having a one nutrient in there, or maybe some fiber. You'll get a star for that. Fortified with iron, you'll get a star for that. So what do you make of fortification then? That sort of randomly adding nutrients to Up and Go or something? Yeah. Well, I suppose it's going in it is a good idea. Fortification was a good idea. It comes from, I think the history is that it comes from pellagra, which was was viewed as an infectious disease back in the 1930s. And it was a good story. It was a good science story where the guy, I can't remember the guy who discovered it, but he he said, no, it's caused by a nutrient deficiency. And he was so confident in his hypothesis that he put his wife in, not himself, his wife in with a bunch of pellagrins, and she didn't get pellagra. So he dispelled the myth that it was an infectious disease and it was associated with the food that they were eating and the deficiency. That led to the fortification with niacin. And I think that's where some of the other ones, soon followed, because that's when we started to better understand the B vitamins that exist in our food. So it's got an interesting history to it. And interestingly, a lot of psychiatric admissions back in the 1930s and 1940s were psychosis as a consequence of pellagra or a nutritional deficiency. So it's something we knew in our history, but we've kind of forgotten it. And it's no longer, you'll never find it in the DSM anymore, but it used to be in there, was that nutritional deficiency was a cause of mental illness. Amazing. Yeah, right.
Hey? So that's fascinating, isn't it? History's lost.
Oh, yeah. No. So it's an interesting story. So I just think we lost our way. We've been lulled into, big pharma and big food has lulled us into these really simplistic ways of thinking about health, how to live. And I'm hoping that we kind of reverse some of those trends and go back to a more holistic style of living.
Okay, so when I actually very first met you, you didn't meet me. I was just watching your TED talk, and you open it with something that I've actually copied myself because I thought it was a great.
That's okay. It's not mine.
Opening line,
story.
But it was about Igor Semmelweis's work, and then I don't know if you also mentioned James Lind, who did the.
That's right. Yeah, the randomized
first trials with
Lyme.
With limbs and limes, and there's various other ones as well. Including the other way around. I'll tell you one the other way around with James Halstead, who invented the radical mastectomy for breast cancer.
Okay.
Without evidence, and after some 500,000 of these operations, where 10% of women would die on the table, another fellow, Bernard Fisher, came along in the 1950s. 100 years after this has been done, started and said, "Hey, why don't we do a trial? Because I don't know if this is the best thing. Maybe we should just do a lumpectomy." And everyone's like, "Oh no, this is ridiculous. It's the standard of practice." And it turns out, it's equivalent, and it saves lives.
All right.
But it was just more to the point of science getting done and then practice taking a long time to catch up. Now,
I know.
How do you feel about that with you? And I just want to put it in context with me as well, because I started my career in physical activity and health, and I've spent the second half of it more in nutrition and health. But when I started in New Zealand in physical activity and health, we were the most active country in the world. And 25 years later, after all the work I've done there, we're now slipped to the middle of the OECD.
Right. So,
basically anything I've done's had no effect in this country, and not worse.
Right. So how am I going to
worry you about your good work?
Yeah, it does certainly worry me. And then I think just to finish the story that I was telling earlier, about stress and that research, is that after after that study I told you about in 2010, where we showed the importance of nutrition for foundational resilience, we then went to show that you could alleviate stress following a stressful event and reduce levels of PTSD, et cetera. And then we replicated that. And there's a whole bunch of research on B vitamins versus placebo showing that it's beneficial to reduce stress. And so I've shared all of that with politicians. And when the mosque shooting occurred in 2019, March 15th, I did everything I could to say, look, we've got enough evidence here of using nutrients to help people who are facing a really traumatic stressor, as traumatic event. There was money pouring into Christchurch to help the victims of the mosque attack, but I could not get anyone to take the risk. I wouldn't even call it a risk, but to have the courage to do something different than what we were doing already.
So nothing happened.
Nothing happened, except that we, as a lab, I felt I couldn't stand and do nothing. So we raised money and we gave the nutrients away, and we monitored them clinically, and we showed the same effect that we had showed with the earthquakes and the flood. That's the work that you were talking about that I did with Neville Blampede, and we published an editorial about how hard it was, all the roadblocks that were put in our way. That it was just a remarkable time of people just saying you can't possibly possibly take these risks. You can't do this. And we did it. And then we showed the benefit. And then since then, I've then gone back to all those committees that said, we're not going to do it. And I've presented them with the latest data, and they just come back and they say, oh, well, that's just observational. It doesn't change our opinion. And you're kind of like, what plan? Like, do you have any desire to help the people in your community? You're okay about giving them benzos that they don't want. You're okay to give them psychotherapy by translation, which doesn't have any research to support it, right? I mean, psychotherapy does, but not by translation. So there's an assumption that it works via an interpreter, and so they're okay to do all of that, but they wouldn't open the door to giving them the micronutrients, and they still wouldn't. And with the floods, the Canterbury floods that just happened, I tried again.
Same thing.
Yeah, same thing. And I'm like, there's only so much I can do.
And when you go onto your iPad or however you read the newspaper, and you see another discussion about mental health and no mention ever of nutrients and all ambulance involved in the clip, how do you feel, and what do you?
That's right. Thanks, Grant.
This is the opposite of therapy.
That's right. I know. You should feel depressed by now. It's despairing. It is despairing in a way. It can't. You can kind of go, I should just. Why am I hitting my head against this brick wall? And I suppose I guess I see myself as being having some level of resilience and optimism that if you try hard enough, you can change. And I've got to stay there, or I might as well give up now. And I know that I'm making a difference on an individual level. I know that I've helped thousands of people all around the world with this research.
And you get others. Messages on that basis, right?
All the time, thousands and thousands of messages. And so that happens. I've had so many messages about the book, just really mostly positive, like, a few grumbles, as you mentioned, but overall, really, really positive feedback. Yeah. And so you've got to go with that. And then, maybe it's got to be a grassroots movement. Maybe that's, I don't know what the solution is.
I've come to that conclusion. I think that's the only way.
I don't think it's going to come from above.
And if you wait for that, you're going to be so terribly disappointed.
Yeah, I know.
So part of our job as researchers and scientists and practitioners in the community is to be part of engaging with that community. Exactly.
And I certainly spend a lot of time engaging with the community. So that's, you can't fault me on that. I've done so many public talks, so many, speaking engagements. So I know there are people out there.
Well, that's the other encouraging thing though, is
they're invited.
That you're not turning up to an empty house here, right?
Never. No.
No, they're selling out.
They sell. Oh, absolutely. I mean, I do the one at, these UC Connect ones at the university, and they take out the biggest auditorium, and they always double it in terms of and they have to put them into the overflow. And so that's not unusual. I did a book launch at Scorpio Books the other day, and it was just, the room was absolutely completely packed. And so that's pretty cool. That yes, it attracts the attention. TEDx is now 1.8 million views, which isn't bad, because 1 million of those I've gotten those since the flag went up. So don't watch this talk, because it's gonna you can't believe it.
I find that one of the more astonishing things in the universe, frankly.
Yes, I know. So
which we talked about before, but
So I know the audience is there. I know that it is already sold. The book has already sold thousands of copies in New Zealand. I don't know if that's good or not. And for after 2 months of launch, maybe you have a bit of insight on that.
Oh no, I mean, you seem to be on fire, and I talk to all these people, and they know about the Better Brain.
Good.
So that's great. And they can get it on. You can get a Kindle as well. You can. Away you go, and I think it's. I mean, writing a book's not a small undertaking, right?
No, it's not not at all. And I think it would complement the fat for sure, because we were asked. There are recipes in there, which I always find is quite amusing, because I'm a psychologist, not a cook. I'm not a chef, but that's kind of that's what the editor said. We needed to be able to really handhold people. Say, okay, when we mean the Mediterranean diet, when we mean real food, this is what it looks like. And so we hired a chef, because I felt we needed that level of sort of, just like you collaborated.
Yeah. I mean, what am I going to do? Like, my wife just laughs that I'm on on
yeah, right.
book, but she's just
Yes,
like, this
exactly.
is embarrassing for you. And I was like, no,
Yeah.
it's not. I've done all the science. Come on.
Exactly. And you collaborated with a chef and with a nutritionist. And so you absolutely, I mean, you got this, you did amazing in terms of getting that credibility behind the book. And that's what we did as well, was to get a chef involved in the recipe development, so that we didn't, it wasn't us coming up with these recipes. It was somebody who
And they're good recipes.
I hope so. Yeah. I think we got a good balance. I mean, we were limited on words and all those challenges you have with a book, but yeah.
Oh, and I think you're going to find it's on fire. I mean, I think with the fact now, we've probably sold 300,000.
Oh my gosh, that's amazing. Across the world.
I mean, it's including the Kindles, because they count for a bit of volume, but
that sounds like a really great number. We're certainly nowhere close to that.
Purely because you're a little bit more focused than we were on such an important problem. So
yeah, hopefully.
And I think that's, and people are struggling to know what to do. And I let's look at parents particularly, and it breaks my heart of parents with, particularly adolescents with more serious anxiety and depression issues amongst other things, and having nowhere to go.
Nowhere to
go. Can you imagine? Well, you can imagine. About it.
I know. And I hope that this, if you read this book and you just got the basic information about where to start, you don't have to see. I don't think you have to see a professional to start making steps towards changing your diet. I don't think people feel that they need to be monitored. Maybe that's because it's just inbred in us about taking supplements to make sure there's no harm. But I think people can take a lot more control of their health, and to take steps that they can do on their own without having to rely on these professionals that don't exist. So they're just not out there. So I do hope that it gives a lot of people that kind of courage and the confidence to get started on a journey of wellness.
And right, have you got your copy that you can just hold up for everyone, and we can?
I do, but it's hard to, because I've got the blur version on.
Oh yeah. Oh no, bring it forward there. That's it. We've got it. The Better Brain. It's a great read, folks. So get into it. It's all about the nutrients. So thanks, Julia. Appreciate it.
Thank you. I enjoyed that.
You've been listening to Prevention is Cure, brought to you by Precure.com, with me, Professor Grant Schofield. At Precure, we're developing a way to help medicine help change the world. We're filling that gap. We're helping train health coaches and mental health coaches. We're bringing short but effective behaviour change programs over 29 days to you, to help you learn for yourself and help others as well be healthier. We're trying to create a community of like-minded people like you, who want to use the latest science and practice to change lives for the better. Join us at Precure.com. Get involved in our communities. We'd love to have you along for the ride. Precure.com.
Too many days in the darkness, without a glimpse of the light. Running tired and broken and scared, but I swear I'll never give up the fight.